Hello, beautiful people. Welcome to this week's episode of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. I'm your host and producer of the show, Olga Peters, and this is where we talk about how everything in Montpelier shakes out for the rest of us. We are continuing our conversation around healthcare this week with Vermont healthcare advocate Mike Fisher, who is the Office of the Healthcare Advocate is through Vermont Legal Aid, and he's here to talk about all things healthcare with us. So glad you're here, Mike.
Good morning. Good to be here. Happy to talk all things healthcare. Why don't I just do a little level set? So the Healthcare Advocate's Office is a position, and I am in a position, and we have an office that is set up in state statute. It's been in existence since 1999, and for its entire existence, it has been through an RFP process housed at Vermont Legal Aid. So while I don't work for state government, my contract, all of my funding, my duties are all defined in state statute. So I'm really doing the work of that's defined by the state.
Thank you, Mike. Appreciate that clarity. And of course, regular contributor, Representative Emily Kornheiser from her lovely new painted office and newly hung pictures in her office. So glad you can be here. And you will have to forgive me, folks, today. It's very ironic we're talking about healthcare today because I spent a few hours, preface this, everything's fine, with a family member who had to go to the emergency room last night. So I'm operating on not enough sleep. But I did get to see our rural healthcare system in action last night.
Yeah. In my world, we call that primary research.
Okay, yes, I did. I had several hours of primary research last night. Thank you. And so I'm a little foggy, folks. I just admit it, and I apologize. Before we dive in deep, I know Emily has a number of questions for you.
Can I also just before let me do just another little touch of level setting. Just to recognize that in my office we have a helpline, and any Vermonter who has any access to care problem can reach out to us. No income eligibility. You just have to be a Vermonter. And 800-917-7787 is the phone number. And I've got a team of great advocates who have been through the trenches and have heard every story and are really happy to do our best to help. That said, there's a lot of times when people call us and say, you know what, our healthcare system is not working for me. And the response is, I'm sorry, the healthcare system is not working well. So we also have a policy team that is informed by the experience that Vermonters bring to us, and we bring your voices to the legislative and to the administrative advocacy to try and change state policy.
Well, before I even jump into my questions, Olga, that helpline works so well. And it works really well, for one, because you often can solve people's problems. And it's really refreshing as a legislator to be able to, who often is trying to solve people's problems, to actually be able to send people somewhere that someone will answer the phone and help them. The other thing that's extraordinary to me, which I do not think happens very many places, is that people's individual issues are elevated to policy issues as soon as necessary. And so people's individual problems are solved, and then if it is part of a systemic problem, that gets flagged. For whatever reason, that communication between line staff and policy is very, very, very rare. And so that is very refreshing to me to know that that's sort of constantly happening, and would love to see it sort of spread across state government. Although we have interrupted you 5 times now. What to do?
Yeah, and we're going to do it again. Emily, it is something that distinguishes the Vermont Healthcare Advocates Office from many. There's great policy shops around the country, state by state, and there's great helplines across the country, state by state. I talk to them all the time on the phone. There's not many where they're in the same organization where they inform each other so well. It's really a very important part of my office.
Well, I'm glad you brought up the helpline because that's what I was going to ask you about is since you do operate this helpline and you are daily hearing Vermonter stories, I'm wondering what are you hearing now? What kind are you hearing any certain trends? Are there certain policy pieces that are being flagged? Are you hearing things this year that you haven't heard in previous years? What's kind of the flavor of Vermonter stories right now?
Yeah, I think we are always sort of a level. A full quarter or more of our calls are eligibility for state or federal programs. People either or transition to Medicare. That's confusing. It's complex. There's dates you really have to get right. Otherwise, you can really be in trouble. And getting some assistance and sort of understanding those transitions is really important. I think we're always fielding a regular set of calls from people who have received bills from their healthcare provider that doesn't make sense to them.
Hmm.
Why am I getting this bill? It doesn't, I thought it was covered. Um, and I think, you're right. I think, well, and then the other just major thing to steer ourselves towards is we're gearing up for open enrollment that starts November 1st. And there's lots of segments of the market that are, if you get your insurance through your employer, um, your employer, often that's easy, it just rolls over to the next year. But for those folks who get their insurance, who don't have employer sponsored insurance and are under 65, don't have Medicare, this open enrollment period is a really important one with some real substantial differences from previous years.
And what are some of those differences?
So I feel really proud. My office pushed for a policy change a number of years ago. We failed for a couple of years. The state government didn't do it, but finally, for the first time, it's in place, and it's a behind-the-scenes insurance rating mechanism that, in effect, is going to draw down a tremendous amount more federal dollars in the form of premium tax credits to help more Vermont families afford richer plans. The outcome is going to be that people are going to be able to buy up to a gold plan. In fact, this year, gold is going to be less expensive than silver in the individual
Ooh,
market on the
what?
exchange. Yeah, I
Wow.
know. It's baffling. It's different from what we've been telling people all along. But the net effect is that people who are in silver plans are going to have an opportunity to buy up to gold often for less money.
That's exciting. That's very exciting.
It's really and I know I just recognize as I'm saying as you're saying this that's exciting, and as I'm saying that's exciting. I just recognize people hate shopping for health insurance.
Yeah, it's terrible.
It's terrible.
It's
You feel like you're
terrible.
being scammed.
Mm.
The language is wrong, is confusing.
Hmm.
And like even though there's like the all the charts to help you compare plans, I always feel like there's something hidden. I need to make my own chart to compare plans. And like, yes. And so my understanding is also like the MVP versus Blue Cross differences are also going to changing
Yeah.
significantly this
Yeah.
year.
So let me get to that in a minute. I just want to fully recognize people listening to this, their eyes are going to roll. They're going to be like, oh, somebody else saying, oh, it's exciting. Open enrollment. You get to shop for insurance. I get it. It's hard. It's confusing. My office is available to help out. And Vermont Health Connect is available to help out. Um, so I, so it is the year to look at the plan you're on, whether it makes sense to stay, to be on gold or silver, to check out those prices. And then what Emily just said is another dynamic. In a regular year, year after year, I kind of like being agnostic between the carriers, Blue Cross and MVP. And we've seen price differences between them over the years, but it's been a couple dollars. Hasn't been substantial. And I recognize there's reasons to choose MVP or Blue Cross that are not about price. um, particularly around providers being in network or drug formularies. So it's just a little bit more complex. But this year, the price difference between the two is substantial, is a really significant difference. And so this is a message. People are making decisions for their small groups, small employers who are thinking about this, or people who are buying for themselves. It's really, it's an important year to look at the costs of both carriers. I spoke a little bit about the difference. I want to minimize that. Both plans in the exchange offer the exact same coverage. The plan designs, there's standard plans that are exactly the same. There's non-standard plans that have some differences. And the networks are really substantially the same. It wouldn't surprise me if someone said, hey, I've got a PT or I've got a mental health clinician in my community who takes one and not the other. But all the hospitals, all the major providers take both of these carriers.
Thank you, Mike. Emily, you're gearing up for the legislative session and healthcare is definitely on your plate. What are some of your questions you're sitting with right now?
Well, the thing that I think is sort of the most top of mind, and that I imagine is going to be the most challenging part of the legislative session, and including what is the role of the legislature in this, is the health of our hospital system. And we talked to Lori about this last week in some depth. And I think we're going to continue talking about it over the next few weeks. But I would really love to hear your take on all of it, Mike. And before we get into that, we have this report. We sort of know that our hospitals are struggling. I've been struggling for a while. We have this report about sort of what health in our hospitals might look like and changes that would need to be made. And I feel like I ask you this question every year when you come on, but where is the money going? Like we have so in a, like the story about America is that it's all for profit. It's all being, price gouged out to multinational corporations and CEOs. But we have nonprofit health insurance. We have nonprofit hospitals. We have a Green Mountain Care Board that's hypothetically regulating all of this. We have you looking out for everyone. Why in God's name is the system collapsing and we're all paying more than we can possibly afford? Where is the money going?
Yeah, my first response is you ask me this question every year because I don't give you a good enough answer. And it's super complex, and there's a lot of factors. Anybody who tells you it's this is not telling you the whole story. And so, first off, because you just focused on profit versus nonprofit, there's a ton of profit taking in our healthcare system, despite having nonprofit hospitals and significantly nonprofit insurance companies, drug manufacturers, PBMs, healthcare IT. There's a lot of profit taking, and unfortunately, significantly, a lot of that is outside of Vermont lawmakers' hands. I think there's some new ground that I think is worth exploring about setting upper payment limits in the world of prescription drugs. Something that's being explored and tried in other states, and I think it's worth exploring here. To just say, I'm sorry, Vermont payers cannot pay more than X for a particular type of medication. This strategy, like I say, is being tried in some states, and it's going to have some litigation. It wouldn't surprise me if there was some litigation, but so there are some approaches to attempt to focus particularly on prescription drug costs. But and then the other thing to say is, despite having Emily, because it wasn't part of your question, let me just say, on top of the stresses that our insurance companies that our hospitals are showing, our insurance companies are showing significant stress too. They're not going to the bank MVP and Blue Cross, the two insurance companies that are in our fully regulated market. Cigna is also in the large group, fully regulated. But significantly, those first two companies are also showing real stress. Their reserves are in some stress or in some trouble. So I think a lot of people, often people in the world of healthcare policy, want to blame either the insurance company or the hospital for what's going on here. And I sort of stand in the middle, feeling critical of all players. But despite having a nonprofit hospital system, we also have to recognize that we have particularly expensive hospitals. Our hospital system is expensive when you look at it on the national scale. And no, they don't like to think about it. They don't like the focus on that. But we have to compare them with a reasonable set of peers. Does not make sense to compare UVM to Brattleboro, for instance. They're worlds apart. But it does make sense. The UVM has peers around the country, Dartmouth, Albany. There are other teaching hospitals that are charging people significantly less for the same care.
So why is it so expensive?
I don't have a really clear answer for you on that. I think some people would jump to executive pay and the number of executives in a hospital. And while that's easy to focus on, it cannot tell the whole story. But I think that, and some people would talk about, so how efficient they are, how, whether the productivity of their providers matches what the productivity should be, at other hospitals. And I think there's some evidence there. But I think, but I don't know. I honestly, your question is a good one. I don't fully know the answer to it. But I do know that it's expensive.
Yeah.
I do know that it's, I'll say out of whack expensive. There's a
And
great national.
Is it just UVM health system, or is it like all of the hospitals around the state?
As a group, we're expensive. UVM is noteworthy. It's hard. UVM is the elephant in the room.
Yeah.
It's just so big that its prices drive so much of what happens in Vermont. So I focus on that.
It's so far out of my frame of reference down here. Like we are Dartmouth oriented, we're Brattleboro oriented, we're Massachusetts oriented. Most of my friends go to Boston regularly for specialists. Like it's just, we're in like a different zone of healthcare down here. And so I don't think about UVM very much.
Yeah, Boston is closer than Burlington for you, right?
Yeah. I mean, the parking is way worse, but it is
close. So on some level, provider rate setting, fixing the variation about what we pay different providers across the state has to, and putting, making sure we have some real tools to control the rate of growth has to be on the legislative agenda. People who are in my world might say in response, wait a minute, the legislature already did that. When I was in the healthcare committee, when I was in the legislature, we did give the Green Mountain Care Board provider rate setting authority, and the board has never used it. And I think that's an error. I think that's something that the board should have done many years ago. But I think in this political climate and in this in the dynamic with all the things in play right now, it makes sense for the legislature. And I'm gonna be honest, Emily, I have not thought this through completely, but it feels in my gut like we need a legislative mandate, filling in some of the blanks about sort of the process that needs to go through to move us to a provider rate setting, using the provider rate setting tool.
I have and this sort of is the questions around hospital changes and possible hospital failures. The idea of provider rate setting has a lot of parallels to sort of the school financing crisis, which is strangely somewhat comforting as the world collapses around us. And one of the parallels that I see is there's an urgency to move fast, because, the world's collapsing around us. And then, sorry, listeners, this is just what you get from Emily in the autumn. And then if you move too fast, you actually collapse the system, right? Like you can't, if say we do provider rate setting, some providers all of a sudden are going to see sort of, like a quarter reduction in revenue, making adjustments to that in a way that actually has integrity to their care and their system isn't possible, right? And so how do you navigate that? And this is sort of, I think, the more boring but more difficult question embedded in that. If you set it out on a multi-year plan so that people have the signals in advance so they can start making the transition, how do you trust the legislature to not bail on the commitment they made in the face of years of pressure if it's not a quick fix?
Yeah, great questions. And, 101, legislative 101, you can't bind a future legislature's hand. And so, I do feel that I'm going to take just a tiny step away from sort of the specifics of what we should do with hospitals and recognize, well, to your point, I wouldn't be surprised if you're not receiving, if many legislators aren't receiving strong messages from hospitals saying on some level, the Green Mountain Care Board doesn't know what they're doing. They're going to destroy our hospitals. They're going to hurt people. In other words, hey, legislature, take away power from the Green Mountain Care Board. It wouldn't surprise me if in a defensive way that is happening already.
Frankly, that was happening long before this hospital, right?
But there might be a new wave of it happening right now,
Yeah.
given that, at least in my opinion, for the very first time, the Green Mountain Care Board is really attempting to regulate this system. I don't think the track record's been great over the years. I think the Green Mountain Care Board has trusted hospitals and trusted the system too much and not put it through the paces.
And I just want to, so I'm just creating further parallels to schools, which might be inappropriate. So push back if you want to. And I'm so grateful to have the solidarity with Lori this upcoming legislative session. One parallel is it's not that like hospitals individually are acting nefariously. It's that they're acting in their own institutional, organizational, even healthcare region interest and not able to see the full picture of the state because that's not their job. And what's powerful about the Green Mountain Care Board, or even the legislature, if it behaves as holistically as I want it to behave, is able to look across the whole state and see the whole system. Individual health systems are going to act in their own best interest and the best interest of their patients, right?
Right. And similarly, I don't know how many schools there are. Emily, how many schools are there?
I don't know.
Lots. There's 14 nonprofit hospitals. There's 14 hospitals, 15 if you include the retreat, which I think we should include. 16 if you include Dartmouth. The bad joke is Dartmouth is the second largest hospital in Vermont.
That's how I think about it. I don't think, is that a bad joke? Seems true.
No, it's just not in Vermont.
Very true.
Like half the providers are like, okay.
But, and those nonprofit boards for each of those entities are making decisions, given the evidence from from their leadership and their communities. And you're exactly right. It is a particularly difficult challenge to think about how to move. I'll focus on hospitals. I think hospitals have more interplay with each other than schools, let me say. When a hospital doesn't provide a particular service, people go to the next community. That's different than schools. So hospitals, we need our hospital system to act more like a single system. And that's something that I think Hammery, the Oliver Wyman report that recently came out, does drive home. And I want to, on a high level, Dr. Hammery suggested a lot of details that are very specific, community by community, that I can't possibly weigh in whether it's a good idea or not. But the overall direction of what the Oliver Wyman report pushes for is something I can attach myself to. If we don't get this right, if we don't right price and right cost our healthcare system, the market will do it for us. And the market's not going to be kind to Brattleboro or to Newport. The market's going to do what the market does. And I think the other thing I've been saying, the party's over. The party's been over for a long time for consumers, but for our healthcare industry, we have for years been able to say it's going to cost more. I'm not going to trouble myself about who's going to pay for it. The system will pay for it. And those cost increases work their way through to increased costs on us, increased costs on us through our taxes, if we're talking about the care of public employees, increased costs on us in our insurance rates, in our premium rates, and in our out-of-pocket costs. And the concept that we could possibly sustain another year or years of double-digit rate increases and the corresponding effects on other parts of the system, and say the taxpayer for the school employees, is tone deaf, is blind to what's really going on. So I think the Hammery report, sort of, for me at least, represents sort of a stake in the ground. We can't keep doing this. We have to right size and right price our provider system, and that is not going to be easy. I don't mean to say it like it, imply that it's easy. To the point you were making earlier, Emily, good providers are doing the best thing they can. Good, administrators of local hospitals are doing the very best they can with the resources they have, and are feeling really challenged by this picture, this dynamic that we're all in.
So I'm going to have to stop you there, Emily, because we need to hear from some underwriters here on WVEW 107.7 LP Brattleboro, your community radio station. So we'll be right back. But Emily, when we come back, what are we going to? What do you want to ask, listener, Mike? Just so we can.
I want to talk about fear of change versus managing change for a minute.
All right. Okay. So you heard that, folks. So don't touch your dial or your little home button on your screen or whatever you happen to be listening to us on. We'll be right back. Welcome back to the second half of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. If you're just joining us, I'm your host and producer of the show, Olga Peters, and I'm speaking about healthcare with regular contributor, Representative Emily Kornheiser, and Vermont healthcare advocate Mike Fisher. Before we dive back into our conversation, I want to quickly thank BCTV for taking the video version of our show and sharing it with media centers around Vermont and even a few throughout New England. I sometimes wonder what we talk about because when I go into the analytics of our show, I'll see like all of a sudden a huge glut of people in Cambridge, Massachusetts watched a bunch of episodes, and then for some reason someone in California like watched a bunch of episodes, and I'm like, what the heck did we talk about? Um, but I think part of that is also thanks to BCTV. So again, thank you, BCTV. And Emily, what are we going to remind listeners of?
The views and opinions expressed here on the Montpelier Happy Hour are those of the host and the guests, respectively, and not the station, nor platform, nor employers or friends.
Why, thank you very much. So, right when we left for break to hear from some underwriters, Emily, you had asked about the difference between change and the difference between fearing change or managing change. Let's dive back into that. What are you kind of thinking?
Yeah, so this is one of my themes for the fall. And it's funny, like therapists often talk about like how all of their patients, clients will all like sort of come in with similar threads over the course of a couple months. Um, and I feel like sort of politically, that's I always wind up in these like random mental frames I carry through everything. Um, so change is inevitable. I don't mean to like be deeply philosophical about this. That's just like, it is also fall. So the things are changing. We have a nice view of it right here. Um, Change is inevitable. We are in a period of like particular change. I think one of the extraordinary things about Vermont, and Frank Bryan, a Vermont historian, writes about this a lot, in that we, in some ways, because of our particularly poor and rural nature, have actually avoided a huge amount of global change because we just are left behind by sort of the positive threads of change. And so we never experience the like downgrade of those positive change. So, one of like the major pieces of that is that like we're actually perpetually in a recession, and that's why we don't experience recessions particularly strongly here in
Yeah.
Vermont.
Yep.
So, okay. So all of that said, there is a lot in Vermont that is particularly poignantly about to is fraying to the point of breaking. And I think we've sort of always joked, and Congresswoman Ballant, I think, has credit for authoring this one, but I don't know if she actually authored it, which is like the whole state is held together with duct tape and baling twine. And the duct tape and baling twine is not really holding anymore. And there are a number of systems, like our school system or our healthcare system, where it's very, very clear it's not working. And if we don't do anything, it's going to get worse. So it's not that we can say we don't want to do anything because this mediocre status quo is something we want to stick with, right? It's that if we don't do anything, the situation's going to get worse. And we don't know exactly even how it will get worse. We just know it's going to collapse further. And yet still, in the midst of that sort of acknowledgement that things are constantly changing, we can't necessarily control it. The desire to actually manage that change is really, really, really hard for people because change is scary, right? And change is scary no matter what, right? And so
So
I
Emily,
just
let me let
want
me
to figure
let
out a
me
better way that I can be like riding that wave along with colleagues and friends and constituents because the change is inevitable.
yeah.
Mike, before you jump in, I think what I would add to that, just for listeners, another kind of look at that change versus managing change. So often when I cover municipal meetings, the big conversation is about like capital improvements and let's save money by delaying maintenance. And then over time, that little problem gets bigger and bigger and bigger and bigger. And pretty soon, what could have been replacing a door is now replacing the entire firehouse. But I think sometimes we fool ourselves and be a little penny wise and pound foolish. Let's save the money, but we're actually not saving money when you look at the big picture. I think sometimes we approach change the same way in this state. Um, what are we saving when we're really not seeing the big picture? So, sorry, Mike.
It strikes me how much of this conversation around healthcare, particularly, has been sort of on the level of, what's life like for a hospital executive or an insurance company executive or a regulator or maybe a legislator, and how little of it has been about, what's it like to be on the ground needing care.
Yes.
And so, you know, part of the obvious answer to your question, how do we manage, what do we think of change? Are we afraid of it? Are we welcoming it? Has to do with change in what direction. So, I think to many Vermonters, and people love their providers, people love when you get good care, you feel indebted, you got good care. But I think many Vermonters already feel priced out of the care that their providers tell them they need.
Mm-hmm.
And so and I think many Vermonters are experiencing real challenges of not having access, not having beyond the price barrier.
Yes.
They can't find a provider.
Mm-hmm.
We don't talk dental. So, obviously a basic, we need change. We need improvement. And for sure, we fear going the wrong direction in that change. Maybe that's a bit of a simplistic answer, but
I think it's a really,
yeah.
I think it's a really important piece of the nuance, because I think the folks who experience the negative effects of a non-managed change first, the people who experience the sort of chaos of a natural occurring system, especially under the particular flavor of capitalism that we're all living in, are those who are sort of the most financially vulnerable or the most geographically vulnerable. And so if we actually want to design systems, we could even look at like the Affordable Heat Act in this context. If we want to design systems that in the global winds of change are going to work for the poorest and the most rural among us, or the most racially marginalized or linguistically marginalized, then we need to actually manage that change because of who is already experiencing that pain, right?
Mm-hmm. That's a good point, Emily. I think sometimes we forget. It's easy in Vermont. Yes, we don't like to change. There's that joke about how Vermonters don't like to change. But I think sometimes we forget that some of the change Vermont has experienced has not always been positive.
What's the actual joke? I don't know the joke. Is there an actual, do you have like a one-liner for us?
No, not a one-liner, but just like, oh yeah, Vermonters, how they don't like to change. Nobody ever likes to change. Or oh, who was it? John Walters put it really well. He said he used to call it the blank stare. When you talk about change in a lot of Vermont communities, you just get this kind of like blank look, like, why would we want to do that? So for the one-liner, ask John Walters.
Let me recognize one positive change that the legislature did last year that Vermonters won't experience until 26. Takes forever to get things done. Is a new eligibility standard for the program that wraps around lower income people on Medicare. Boy, Emily, it's been a little while since I've talked numbers. My memory is it was around 12,000 Vermonters are going to have new coverage, and it's going to draw down substantial federal dollars. The state only had to put up something like 4 million.
3 million? 2 million?
3.7
million?
I can't remember.
I never remember numbers, Mike. So I don't,
Only a handful of million, a couple of million, and is drawing down, tens of millions of dollars in order to help this really vulnerable set of Vermonters get care. So we're looking forward. We're working with the Medicaid office to sort of plan for that change and for getting approval from the federal government for it, and sort of the cascading effect that it has on some other programs, making sure that they're going to align well. So that was a success from this past year's legislature that I'm really looking forward to actually seeing in place January 2026.
Me too. And then we also did something around prior authorizations. And I'm curious sort of what you're expecting to see from that.
Yeah, I got to admit that I was a more critical voice on that bill. I know that many legislators were very proud of it, and I was particularly concerned. The effort I'm wholly in favor of. Prior authorizations are a place of an opportunity for a lot of errors from the provider side, from the insurer side. And it's not uncommon that people call my office and say, they might say, my insurance company's, messing me up. And it might not have been the insurance company. It may have been the provider who didn't do the right form, do it in the right way. So simplifying, aligning prior authorizations is something that we definitely have to do. And I was really afraid. There were other parts of that bill, claims edit standards in particular, that I was really afraid that the legislature took too big a step without fully understanding the consequences. We like to say the big bad insurance company is messing things up, but the big bad insurance company is also the one there to say, you know what, your provider billed twice. You know what, your provider billed things that you didn't actually get. You know what, your provider, and or you know what, the course of treatment isn't. We don't want insurance companies to play doctor, but we don't have a lot of checks in the system. And I guess what I'm trying to say is that the insurance company practices here are one of the ways to try and make sure that we don't have waste. And so there was some pushback. There was a whole piece of the bill that Emily, I've only seen this a handful of times in my long career of focusing on the legislature. In a single day, the legislature introduced and passed through all stages, both houses, a bill to postpone a section of that bill, the prior authorization bill, and that was the section on claims edits. So that didn't go into effect this year. It's been postponed for a year. And I think you're going to have to spend some more time on it next year. I think it's coming back at you to with some more thought from the insurance companies about how to make it work.
It's really interesting. And it was sort of extraordinary how quickly that process happened. And
yeah, and I think this goes a little bit to the change thing. For viewers, listeners who don't know, I spent 14 years in the legislature, so I'm kind of familiar with both sides of it. I get it. Legislators want to fix things. I see a problem. I see a path to fixing it. And as frustrating as it is, this change should be slow and careful and deliberative. Mm-hmm. And so there are times when we have good ideas that we really need to test out to see how they play, and test it on a smaller part of the population and incrementally increase it if it makes sense. Mm-hmm. That this is some circular conversation, Emily. This goes back to the concern that you said earlier. How do you stop a future legislature from undoing your work? And you can't. You got to prove it, and it's got to work well in order for the next steps to happen.
And what's really hard about that is like some real meaningful changes actually take multiple years to do well, and if you interrupt them halfway, you've actually sort of, the first tranche has harm caused to it, and right. Sometimes we need to be more um,
Resilient?
no, sort of, we need to stick to our theories of change a little more consistently in order to actually understand if we're making a difference, in order to make a difference. And
some of this discussion sort of hinges on whether you're a moderate or a radical or conservative, or I mean, that we have these labels for these things. And I'll just say again, for those who don't know who I am and my legislative history, I was in the middle of the big push to move towards government financing of our healthcare system. Not a moderate, careful, small change. So, and it, didn't happen. But I guess I wanted, as I'm sounding like a, hey, be careful, do things carefully voice, I wanted people to know that I come from a pretty progressive, real push for change place in my professional career.
well, I think it's interesting, and sort of moving away from healthcare for a second, if that's okay, Olga. I think it's really interesting the balance between sort of being a person who sees the suffering that Vermonters are experiencing, wants to lessen that suffering, has sort of a progressive theory of change about how to lessen that suffering. And yet, I'm speaking for myself, and I think it applies to you too, Mike. So feel free to tell me I'm not, and is a technocrat in the best sense of the word, right? And I know that word has like, a little bit of dirt to it, but I think once you understand how fragile our systems are, and how hard the individual people are generally working within those systems, and how easy it would be to push any of those systems to the point of break, and how complex and uncoordinated those complex systems are. It's an interesting piece of sort of like, virulently pushing for change, knowing that the system probably can't quite handle it.
Mm-hmm. Emily, as you're getting ready for the legislative session coming up, I know we're a few months away, but December always seems to have a lot of reports coming out for the next session. And so you are still kind of gearing up. And of course, open enrollment will be starting soon with for around healthcare. So I'm curious, you had asked that we have these conversations in part to prime you for the legislative session. So I'm curious, in the big picture that you and Mike are kind of looking at, are there parts of that you're zoning in on that are concerning you the most, or um, levers that you feel really need to be pulled that haven't been pulled?
That Medicaid wraparound expansion that Mike described, we passed out of the House a much more expanded version of it than passed eventually. And that feels to me like one of the most useful things we can be doing is to be steadily expanding that coverage.
Mm-hmm.
And so that's something I'm looking at. And I fear that it will not be possible to put any attention into sort of progress in the face of what our hospital system or our LAC-O system will need. And so it's really like that report regarding the hospitals is a big standout issue for me that I think is going to take some energy this session. And the other thing that's going to take a lot of energy this session, and that we have not talked to either of our last two folks about, and I really need to spend more time gearing up for before January, is the way our mental health system serves our communities, both regarding substance use and non-co-occurring issues, and particularly how it serves our school system, but how it serves our communities and our more struggling communities, Brattleboro among them. And so those are the pieces. And then there's just like that our health insurance premiums are going to go up again, and like who the hell can afford any of that?
Just the little things.
It's a
Just the little
lot
things.
of
You know,
things.
let me. This is sort of more in theory.
Mm.
Yeah, no, it's not. It's in reality. It's tangible too. Yeah, you know, there's this basic concept in mental health care about giving people the best care in the least restrictive setting. Um, we want to make care available to people in the community so they don't get sick and need to be, you know, in a more restrictive setting. And and so there's been a whole sort of long line of you know efforts and pushes and analysis of how well we've done on that. There's a real similar analogy in the rest of healthcare, and um, you know I just want to reflect for a minute on you know healthcare 101. Everybody who focuses on this knows, and everybody who thinks about it for a minute knows what makes us well is not what happens in the clinical setting.
Yes. Thank
Yeah.
you.
You know, it
Yeah.
happens in our communities. It does happen in our mental health access to good care. It happens in our environment. It happens with good access to food. You know,
Housing.
and stability in our lives. Yes, housing. Um, and Yet in healthcare, we spend every waking moment thinking about what happens in the clinical setting.
Mm.
And we
Mhm.
spend, what is $6 billion? Um, Not all, but substantially on what happens in the clinical setting. Now, we can't ignore it. You need heart surgery, you need heart surgery. No one's going to say, oh, you know, you should have eaten better. People might say
Hmm.
that, but it's too late. People need care. People need care. And, but I just reflect, there's this the big conversation about hospital financing is significantly about the clinical setting, um, and um, you know, there's some analogies to, you know, there's some sort of shadows of this in these conversations, but you know, as I'm thinking about sort of what can the legislature do, what should we be doing, um, it's really low tech. And it's in our communities. You know, there's some great efforts to do community nursing, having towns hire nurses to be available. There's some efforts down your way, Emily, to do a better job in that. We have some programs. There's a program called SASH, which
Hmm.
is it's a really base, you know, on the face. Hey, if anybody doesn't know, I'm trained as a social worker. I grew up as a community provider in rural Addison County, providing care to teen families. Um, you know, SASH is in the most basic level, the most obvious thing to do for elders. You know, you bring care and care coordination to them and wrap around them where they live. Guess
And you
what?
know, down our
It
way, Mike
works.
also have piloted Sash for All
Yes,
in Windham County,
yes.
which is pretty
Oh, I didn't know
extraordinary.
that.
So it's doing that
There's a
same
great
thing for elders for folks who live in affordable housing.
you know, SASH costs this. We worry about, honestly, we don't know where SASH funding is coming next year.
Mm.
It's $5 million. We could tenfold the effort on SASH and still not do enough to really provide care for our elders around our elders and others, maybe other populations as well, um, who we know need partnership. Um, and Again, as a social worker who has a lot of experience, you know, bringing care to people's home, you know, in my case, I was visiting, you know, teenage parents and trying to help them do the best job they could. Um, uh, People don't make it alone. People don't make it on their own in this world. People make it with support,
Mhm.
and some people have natural supports, and some people need our help in getting those supports. Um, so I think you know, I think we can't forget that. there's some stuff that's right in front of us. It costs money, and I know, Emily, you don't have all the money you want to have, but it doesn't necessarily take a big payment reform effort to do some of this stuff.
Mm-hmm. Thank you, Mike. We have just 2 or 3 minutes before the end of the show. Emily, do you have any last minute questions for Mike?
No, I just, if folks want to have deeper conversations about this, you know how to find the Montpelier Happy Hour, you know how to find me at emilykornheiser.org. And Mike, I'd love you to just share with us again all the resources available for open enrollment.
Mm-hmm.
Yeah, and so thank you, Emily. That's exactly where I was going to go. This open enrollment's really going to be different. Gold is going to be less expensive than silver. That's a real change, and it's going to really warrant a lot of people in the individual market to take a look at what they have. I didn't say this earlier. Vermont Health Connect is going to move a set of people to a plan, from a silver level plan to a gold level plan. They're going to map them to the most similar plan with lower cost sharing, lower premiums, and lower cost sharing. So it's great. There's going to be a set of people who are going to see the benefit of that. But there's a whole bunch of people who need to contemplate moving to a different metal level. And on top of that, the price difference between the carriers, that goes to pretty much all incomes, that it's worth taking a look at. And I'll just recognize there is a set of people, very low income, between Medicaid, 138% of the federal poverty level. Don't you hate it when someone says poverty level and doesn't say the number? Mm-hmm. The poverty level's about $15,000 for a family of one.
Okay.
And so between 138% of the poverty level and 200% of poverty level, who we're really worried about, who we really need to partner with them, help them take some action to get in a plan that doesn't have a significant premium increase for.
And that's what you're most concerned about for these folks, is the premium increase?
For that set of folks, very low income people, yes, there are about 4,000 Vermonters who will see a prohibitively large premium increase if they don't switch plans.
Okay.
It was not foreseen when the rates were being decided, just how this would impact that population of folks. So that's what I'm going to be doing between now and the session starting.
Well, thank you in advance for your work, Mike, and for your help. Unfortunately, we are out of time here on the Montpelier Happy Hour on WVEW 107.7 LP Brattleboro, your community radio station. But Mike, before we go, remind folks the website they can go to find more about your work and how to contact advocates.
So, I mean, you can look up the Healthcare Advocates Office at Vermont Legal Aid. I don't have that website committed to memory. Or you can call us at 800-917-7787. I do have that number committed to memory. We're happy to be of assistance. We advise people who are looking at plan selection to go to Vermont Health Connect first. Try it out, see if they can make it work. For many, many people, that system's working way better than it used to work. But if you have a problem, if something doesn't make sense, if you need some advice, feel free to call my office too.
Thank you. And Emily, remind us of where people can find you.
Folks can go to emilykornheiser.org and you will find my phone number, email address, opportunities to connect, or just find me walking down the street in Brattleboro.
And as always, the Montpelier Happy Hour is on the radio every Friday at 2, rebroadcasted on Wednesday, and you can also find us wherever you subscribe to your podcasts. Thanks for listening, folks, and have a good weekend.